guys have a little work for us today. My name's James Beaulieu. I'm a psych major here at CSUMB, going on to my master's program in therapy and professional clinical counseling. I'm here to talk about direct-to-consumer pharmaceutical advertising and their effects on the behaviors in seeking therapies for people today. A little background, what got me interested in it is that we're such a young science, and for so long we've been operating to treat behaviors as if they're part of the medical model. And what I mean by that is, like, if you have a severe cut on your arm, you go to the emergency room or the doctor, it's bad enough and they give you stitches, and that fixes that cut. And I think that we're treating behavioral issues much the same way. And even when in the medical model, you wouldn't treat a rash with stitches. So I look at it as we're treating all mental behaviors as severe cuts with pharmaceuticals, when not all of them are. Some of them are just rashes. And that's what got me interested in what is affecting people's decision for pharmaceuticals. And so I started to research it. But before I get started on what I researched, I'd like to show you a video. This is the first antidepressant video that was released. So this is the Zoloft commercial. It's talking about depression. It's talking about the symptoms that persist for 2 more weeks. That's only one symptom of depression. Of course, it doesn't go on to anything else. That's not a diagnosis, a complete diagnosis.
Prescription Zoloft works to correct this imbalance. You just shouldn't have to feel this way anymore. Only your doctor can diagnose depression. Zoloft is not for everyone. People taking MAOIs or Pimozide shouldn't take Zoloft. Side effects may include dry mouth, insomnia, sexual side effects, diarrhea, nausea, and sleepiness. Zoloft is not habit forming. Talk to your doctor about Zoloft, the #1 prescribed brand of its kind. Zoloft. When you know more about what's wrong, you can help make it right.
So that was the first DTCPA for antidepressant, for that particular antidepressant. And you notice at the end, to talk to your doctor, not your psychiatrist, not your psychologist, doctor. So are these advertisings affecting the behavior in prescription therapy more than other therapies? I got a question. Do you guys know how many countries the DTCPAs are legal in? 2. The United States and New Zealand. The only 2 countries that approve of such advertising. So the question is pretty simple. It's a yes or no answer. So my first study that I looked at was Frankenberg et al. In 2004. Used college participants. Used 3 measures: demographics, BDI-2, which is the Beck Depression Inventory Scale, 2nd edition, and then a depression questionnaire of the participants when they were done. We had 2 groups, so it was random assignment. So we had the DTCPA group, which shown not videos, but just literature, and then a group that was shown scientific information about depression and treatments. Staggering results. 40% of the DTCA group came out of the study wanting to seek that particular advertised antidepressant. And only 6% in the scientific group had the similar feelings. The study size was small, but the methods were good. So I thought it was worth talking about. But I also wanted to continue my research into a bigger study. So I looked at Block's study. His study was it originally started as a cost to benefit ratio model, where he was taking a lot of information and plugging it in to generate a dollar amount, cost and benefits. But what he found out by doing it was a lot more. So he used a huge data pool, self-survey report with physician surveys, and the estimated data on prescriptions filled. That's where he was getting his cost, dollar amounts, prescription filled. even more depressing data. The amount of new antidepressants described from people that sought a doctor visit due to the DTCPA was 98%. Of those people, only 94% were not depressed on any scale. And 6% were actually diagnosed, which I just thought was huge. And how we came up with the data was very impressive, coming up with how many prescriptions were filled through the data surveys, who was actually depressed, who was diagnosed depressed. He got that from doctor survey. So I believe that information is very accurate. And this isn't that long ago. 2004, seems like 12 years. It's not that long ago. But with all research, there's always a counter argument. So I looked at those studies too. So Freeman and Gould used, their current study had 321 participants phone survey. Based off the questions from the FDA surveys of 2002 and 1999. And that data was available to them because it was published. This survey contradicts my argument a little bit. In 1999, 83% of people sought out meds from the DTCPAs. It rose in 2002 to 89% of people that were seeking prescriptions was from the advertising. The current study, 2007, way lower. Only 18% of the people that were seeking meds were from DTCPA. So, what is that? What does all these studies say? Well, they do all support my thesis in that it is altering behavior seeking due to the data that we see. But what are we going to do? What do we do about it? And then if they're not having any effect, and people don't like them, don't want to see them, are they of any use and should they even be allowed? They're not allowed in these other countries. Why are we allowing them? And that brings me to my conclusion, is where we should go. I think for the time being, we should make them illegal. We should prohibit them until they can have better regulations to include the importance of seeing a psychiatrist and a psychologist before thinking about the medicine. And that probably won't happen. So I think that the best solution is to do what the majority of the world has done and not allow people to be influenced by this type of advertising. Thank you very much.